My name is Ben Kafka, visiting fellow from UT Southwestern. I'll be talking with you today about cervical spondylotic myelopathy. So cervical spondylotic myelopathy is spinal cord dysfunction resulting from a chronic non-traumatic compression. It is the most common cause of spinal cord dysfunction in adults, and it usually encompasses osteoarthritic degeneration, but in the literature and out there, it is often classified with many different things in different ways, and sometimes you can get ligamentous aberrations grouped in with this, such as ossification of the posterior longitudinal ligament and ossification of the ligamentum flavum. But those are considered to be more genetically predisposed conditions. So I'll try to limit the discussion today to cervical spondylotic myelopathy, but just know that a lot of the data is mixed on if it includes entities such as OPLL or not. It was first, cervical spondylotic myelopathy was first described by Brain in 1948. And it is a subtle, non-specific presentation most often with an insidious onset, loss of manual dexterity, weakness, sensory changes, stiffness, urologic changes, gait imbalance, and upper and lower motor neuron signs. It is difficult to really estimate the true incidence and prevalence of cervical spondylotic myelopathy because of its insidious onset. It usually presents late. It's often misdiagnosed as just regular aging or some other neurologic entity, and it's often very mild. So a lot of patients go for years without seeking medical attention. And then in the literature, it's often grouped and studied based on the way it's managed or even the way it's classified. Like I said, if you group OPLL with it, or some groups even group it as a in the spinal cord injury, traumatic injury groups. And so it's really difficult to get a good handle on what the true incidence and prevalence of it is. But it's thought that degenerative spine disease accounts for about 54% of non-traumatic spinal cord injuries in North America, with an incidence of about 76 cases per million. Bogart and Bartels looked at their group of surgically treated patients in the Netherlands and estimated the prevalence in the Netherlands to be about 1.6 per 100,000. Wu looked at hospitalized patients in Taiwan and came up with a number of incidents of 4 per 100,000. But again, you're looking at just surgically treated patients in one study and only hospitalized patients in another. Nori tried to estimate the North American numbers and came up with about a 4 per 100,000 for incidence and a 6 per 100,000 for prevalence. But this is a disease that's becoming more recognized and more aggressively treated. And from 93 to 2002, we saw a 7-fold increase in surgery for the cervical spondylotic myelopathy, and it is becoming one of the more common indications for surgery on the cervical spine. So the pathophysiology of cervical spondylotic myelopathy starts like all cervical osteoarthritic degeneration. You get loss of proteoglycans within the disc, which leads to loss of water molecules, loss of turgor and elasticity of the disc, which leads to changes in loads across the cervical spine. You get a differing load distribution across the vertebral body. You get increased loads on the facets and the uncovertebral joints. And all of that can lead to degenerative spondylolistheses, disc herniations, osteophyte formation, and ligamentous hypertrophies. And those entities lead to a static compression. They can also lead to a stretch upon the spinal cord. And then in patients with this degenerative spondylolistheses, you can get a dynamic injury. And it's thought that these repetitive microtraumas and compressions actually lead to some form of ischemia within the cord, possibly due to direct compression on the arterioles on the spinal cord and or compression of the arteries that lead to the spinal cord, like the radiculomedullary arteries as they come through the foramen can be compressed by osteophytes. Or there could just be an increased perfusion pressure within the cord due to compression of the paravertebral venous plexus. But it's thought that those events likely set off a unique biological cascade that leads to things like gliosis, cavity formation, degeneration of the main cortical spinal tracts. You also get degeneration of the extrapyramidal tracts, interneuron loss, and atrophy of the anterior horns and motor neurons. Now, within the kyphotic patient, it's thought that a lot of the pathology comes from the spinal cord somewhat being draped across these degenerative processes, disc herniations, and thickened ligaments, because the spinal cord is somewhat tethered anteriorly via the dentate ligament and the nerve roots. And so it's thought that as the spinal cord is pulled forward across these entities in a kyphotic spine, you get an increased stretch and increased perfusion pressure within the cord, which leads to a lot of those same biologic processes. So there's good histopathologic evidence to suggest there's ischemia to the parenchyma. Again, this is thought to be due to hyalinization, due to repeat compression of the arterioles, as well as compression, like I said, of the radiculomedullary artery in the foramen. The stretch on the parenchyma too, like I said, in the kyphotic spine, can be damaging to the endothelial cells and alter the microvasculature. Here's a study of a animal model that looked at laminin, which is a protein important or in the basement membrane of arterioles. And you can see in this normal specimen, there's pretty dense laminin throughout the cord, but in this spondylotic model, you can see there's a drastic decrease in the amount of laminin, which would demonstrate that there is a possible decrease in vascularity and likely ischemia. And so this ischemia leads to an ionic imbalance in neurons, which leads to a loss of ability to maintain a membrane potential, and then likely leads to glutamate excitotoxicity and secondary injury, much like you would see in an acute spinal cord injury. There's also thoughts that once this excitotoxicity happens, you can get a secondary neuroinflammation with activation of the microglia cells, the macrophages, and even due to the repeat compression and ischemia, you can get breakdown of the blood spinal cord barrier, which leads to infiltration of the peripheral immune system and leads to even more chronic injury. And this has been shown to be present even in late stages of the disease. But the true pathophysiology has not really been elucidated. And there are some countering points, because from a molecular standpoint, if it was a pure ischemic process, you would expect cells to undergo necrosis. But in many specimens, all we see is apoptosis. And in animal models, there only seems to be mild ischemia, even the most severely symptomatic models. And then in cadaveric specimens, there's only ischemia in the most severe of stenosis. And there have been a few studies that have looked at blood flow status post-decompression, and it really doesn't seem to show much change in blood flow after the decompression, suggesting that maybe that's not what's going on. And here's another animal model of myelopathy. And this first microscopic image stains for choline acetyltransferase, which is present in motor neurons. You can see that most brightly here. Then you can see cleaved caspase 3, which is a protein in the apoptotic pathway. And when you merge those, you see these anterior motor cells are undergoing programmed cell death and not necrosis, suggesting that maybe ischemia isn't the only thing going on. Myelopathy was initially thought to be a disease with a tendency towards stability, but it's now thought to alternate between different declines, either stepwise or rapid. This was first described in 1956 by Clark and Robinson, and they reported what they saw as 3 different deterioration patterns. About 3/4 deteriorated in an even stepwise fashion, 20% deteriorated in a slow, steady progression, and then 5% had a rapid decline then remained stable. Kafka did an interesting study where he watched a series of patients that were being managed conservatively over years. He watched videos of them doing their activities of daily life and categorized them as declining, improving, or remaining the same. And over the years, he noted that 6.3% of patients seemed to decline at 1 year, 20% of patients declined at 2 years, and about 27% of patients declined at 3 years. And Kardamas did a systematic review of the literature and came with the conclusion that about 20 to 62% of patients experienced some sort of clinical decline as followed by MJOA over 3 to 6 years. This bar graph is from another systematic review of the literature on natural history. And what you see is the duration of the study here, and then the percentage of patients who had some sort of decline via JOA, MJOA, or NURIC. And you can see quite the range. There's all the way from only 3% of patients declining at 6 years to 62% of patients declining at 2.5 years. Oshiyama did another study looking at the natural history of the disease in 45 patients who had T2 signal on their MRIs and were being followed non-operatively. And he chose to do a Kaplan-Meier curve where he looked at a surrogate for patients becoming symptomatic as their transition from conservative to surgical care. And in his cohort, at 5 years, 82% of patients remained in the conservative care cohort and had not undergone surgery. And then by 10 years, 56% of patients still remained without deterioration. Another question on the natural history of cervical spondylotic myelopathy is if these patients are more susceptible to trauma with rapid decline. And Bednark did a study where he was watching his conservatively managed patients, and 14 of those patients suffered some sort of trauma, but only 1 seemed to have worsening of his symptoms, whereas in the same cohort, 185 patients who did not have trauma, 44 developed worsening symptoms. But this was countered by Cateau, who found that in his conservatively managed cohort, 8 patients suffered trauma and 7 had worsening symptoms. And throughout the literature, there's many papers trying to find prognostic factors that would help us determine who is going to have a more rapid natural history versus who's going to have a slow and steady, maybe even stagnant natural history. But there doesn't seem to be any firm conclusions. Many things have been factored in, and some of those are increased cervical range of motion, female sex, segmental kyphoses, a cervical SVA of greater than 4, older age, smoking, psychiatric disorders, spondylolisthesis, myelomalacia, increasing JOA scores, and extent of compression have all been found to have some sort of link to a more rapid decline. So again, when we diagnose it, you're looking for weakness of the hands and the arms, atrophy. You can get clumsiness and fine motor. You can see upper motor neuron signs such as the Hoffman's, the inverted radial reflex, the Babinski, but you can also see lower motor neuron signs because as the spinal cord is getting compressed, you can also get compression of the peripheral nerves within the foramen. So you can end up with a more classic glove-like sensory loss, but you can also end up with a more peripheral radicular type sensory loss. But you often see a proprioceptive defect in these patients. And when you assess them, you can look for use things like the 9-hole peg test, the grip and release test, time gait, 30-meter walking test, tandem gait. And the classically described gait of the cervical myelopath is a wide-based ataxic gait with a difficulty in tandem gait. And things to keep in mind on your differential when you're looking at these patients are things like ALS, but in ALS, you would expect to see a lack of sensory changes. You can see fasciculations on exam, cranial nerve deficits, and in DMG with a denervation pattern. You should think about things like MS and NMO, which can have a waxing and waning deficit, but can also have a more stepwise decline. And you can have patients with both. You can have a patient with MS and osteoarthritic change, which could have myelopathy. So it can be difficult in those patients to determine what is the causative neurologic process. You should look for things like tumors, intramedullary or extramedullary can give these kinds of symptoms. In older patients, if they have cognitive changes, MPH is something to consider. Guillain-Barré would present with more absent reflexes, cranial nerve deficits, and autonomic dysfunction. You can also get brainstem and cranial lesions that can mimic cervical myelopathy. When we're diagnosing these patients, it's important to get weight-bearing x-rays to evaluate for alignment, to look for instability and subluxation. You can also get CT scans to show ossifications. That will also show ankylosis and osteophyte formation that may alter your surgical plan. You should also get an MRI, which will show your compression. It can show T2 hyperintensities within the cord and T1 hypointensities, which can display some sort of damage to the spinal cord. Some people are using diffusion tensor imaging to look at the integrity of the tracts of the spinal cord. And as I noted earlier, you can get breakdown of the blood-spinal cord barrier due to the repeat trauma and compression, and that can lead to some subtle contrast enhancement within the spinal cord as well. EMG and nerve conduction studies are less specific and can show longer wavelengths, higher amplitudes, and polyphasic motor units. And once you've diagnosed myelopathy, it's important to grade it to follow it over time. You can grade it with things like the Nurek scale, as you can see here, but that seems to be less sensitive and responsive to change. Or you can use the MJOA or JOA. The MJOA is just the JOA without a sensory assessment of the lower extremities and trunk. And the JOA was initially described as the patient using chopsticks for fine motor, but it's been changed to a spoon to increase the generalizability. So although there's little data to support it, and it's usually only reserved for patients with very mild symptoms or who have extensive comorbidities precluding surgery, you can conservatively manage these patients. And things that have been reported are analgesics, physiotherapy, spinal injections, orthoses, intermittent bed rest, avoidance of high-risk activities, environments, and cervical traction. But there is no good data supporting conservative management alters the natural history of this disease. So the cervical management of cervical spondylotic myelopathy could easily be the topic of multiple talks, and I will just try to hit some of the high points. You'll find many tables like this out there with things to think about and try to direct you on your way as you're planning surgery on these patients. Things like kyphosis, you should probably think to go anteriorly first, or if there's more long segment compression, posterior might be a better option. In the elderly, posterior might be a better option, things like that. But there have been many meta-analyses looking at this, and Liu's meta-analysis showed no apparent difference in neurologic recovery for multi-level cervical spondylotic myelopathy between ventral and dorsal approaches. interestingly, complications, reoperations, and blood loss were higher in the anterior approach, which is in complications was largely dominated by dysphagia, but it's interesting that blood loss and reoperations were higher in the anterior, which is contrary to my experience. Length of stay is longer in the posterior surgery, mostly dominated by pain control. But the authors did note that this was pooling of a bunch of low-level studies with varying techniques and surgical indications. And so the data is very heterogeneous, and it's difficult to make a firm conclusion. Gogawala did a nice study that was published last year in JAMA, and he did a randomized controlled trial comparing ventral versus dorsal in patients with multi-level disease who are neutral to lordotic. So it did create some level of clinical equipoise. And at 2 years, the SF36 and NDIs did not differ in the ventral or dorsal groups, and both meant minimal clinically important difference for improvement. And the 1-year health utilization at MJOAs also did not differ. And health utilization took into account things like reoperation, repeat hospitalization, need for physical therapy, and prescriptions. The ventral did have a higher risk of complications, but again, that was dominated by dysphagia. Mumeni also did a systematic review and looked at surgical approaches and found ACDF versus laminectomy. They both had good short-term results, but the laminectomy seemed to have a risk of a late decline. And then ACDF versus LAMI fusion, laminoplasty, both show comparable results. And then laminoplasty versus LAMI fusion also both seem to have comparable results. But again, this is limited by varying studies, varying small studies with very heterogeneous strategies. So this is all class 3 evidence. And again, as you go through the literature, you'll find many of these types of flow diagrams that can help you to be more thoughtful with your surgical planning. And some of them are very helpful. So it's interesting, when I was an intern, I remember my chiefs telling me when I would see a patient in clinic that when you see a cervical myelopath, you tell them that the reason for surgery is to arrest progression and not to improve. But that's actually not what we see in the literature. Alfifi et al. Did note that patients with T1 hypointensities and clonus and spasticity did do worse after surgery, but that's likely because they have a very late stage of the disease once you have clonus and spasticity. Hawley et al. Noted that elderly seem to do about as well as patients who are less than 65, but they did have a higher complication rate, but that does not seem to alter their patient-reported outcomes or their neurologic recovery. And then in 2013, the AO Spine Group published their North American study where they took all severities of the disease and they left the approach to the surgeons. And at 1 year, there was clinically significant improvements in the MJOA, NURIC, NDI, and SF36. And interestingly, the change in JOA was most seen in the severes and then less so through the other groups. So that was expanded to an international study. And again, they used all severities and left the approach to the surgeon. So these studies are very generalizable to everyone's practice. And at 2 years, there's statistically a significant improvement in functional, disability, and quality of life outcomes. And again, all of these passed the minimally clinically important difference. And you can see how much they improved there below. Shamsi et al. Then also did a meta-analysis of 32 studies. And you can expect then, from his conclusions, you can expect on average a patient to increase their MJOA by 1.92, almost 2 at 1 year if they undergo surgery, increase their NDI by 18, decrease their NURIC score by about 1.5. And all of these, again, are over the minimally clinically important difference. And then as we look at this, it's important to remember, is this cost effective? And I found one cost analysis, which was by Fellings, and he noted that the average quality adjusted life year was $32,900 per quality adjusted life year, which was noted to be right near an often used benchmark of knee replacement, which is about $30,700 per quality adjusted life year. So in conclusion, this is a cervical spondylotic myelopathy is an insidious onset disease that we need to be looking for. We don't really know the true natural history of it yet, or we don't have the best decision-making tools to determine who is going to have a more rapid decline and not. We don't truly know the pathophysiology yet, but I think there's making good strides. And if you're thoughtful about the surgical indications and the surgical strategy, these patients do improve, and they do improve in a cost-effective manner. Any questions?
Hey, Ben, that was great. I mean, I think you kind of nailed it, and a very nice summary of the literature. So I work closely with a lot of neurologists, and we have a pretty robust MS practice at Scripps, and so they're constantly getting MRIs of the neuroaxis, and oftentimes that'll incidentally discover pretty severe stenosis in the cervical spine. Sometimes even with like T2 signal change.
Mm-hmm.
So I think Cody and I on Tuesday saw a lady that had like really severe stenosis and T2 signal change, and she was just getting surveillance MRIs because of MS. But then on neurologic exam, she was pretty much normal. So what would you tell somebody like that? Would you discuss surgery? Would you monitor them? What kind of advice would you give somebody that even has T2 signal change?
I would counsel them that I think of all of the data, I think they will decline over time and eventually, and that surgery can help you improve, but that if you want to watch it and you want to just be counseled on the symptoms to look out for and present immediately if you develop any symptoms, I think that it's reasonable to watch. But especially in an MS patient, things can become very cloudy, and it can be nice maybe to take the compression off the table, but it's really hard to offer someone in that who is stone cold normal. So I think I would favor watching them and just extensive counseling, maybe scheduled follow-up so you can keep an eye on them and just go from there.
Yeah, I think that's perfect. And sometimes the image kind of compels you to act, or makes you want to act as a surgeon. And they'll come to you maybe as a second opinion. And they'll have seen somebody in the community that told them that they're going to go paralyzed any day now. Clearly that is not the natural history of the disease. We know that from multiple studies.
Yeah.
And one thing that helps me, I think, in those folks who are maybe low grade clinically or minimally symptomatic is their upper motor neuron findings on exam.
Mm-hmm.
I don't have good data on this, but just empirically, if somebody is relatively well preserved in terms of coordination and balance, strength, but all of their reflexes are pretty affected, that is to me some clinical evidence that there is spinal cord dysfunction, even if it's more signs than symptoms. Sure. And I feel as though that maybe portends more rapid progression, although I don't have data to support that claim.
No, that would make sense. Yeah. Once the upper motor neuron signs, that may mean that there is some of that ischemia or inflammation going on, and it's just not out in the peripheral nervous system yet. And that would be something that, could be good to intervene on more early.
I think then you also have to look at what you have to do. If it's a single level ACDF in that setting, that might be something that weighs in on that equation of risk and benefit versus a C2 to T2,
Mm-hmm.
That might push you over the fence, but I agree with everything you've said. I think there's one of the other big challenges we face is this arena of maybe they have muted reflexes because they're hypothyroid or they have peripheral neuropathy or as Hanny said, they have MS. There's something else that creates a burden of dysfunction, but it's not totally clear what the cord is contributing from a compassion perspective. I find those challenging as well, making a decision to intervene or not.
Mm-hmm. No,
that's a great point. It's a great point. And if you're in your 70s, it's a pretty good chance you're not awesome at tandem gait. So I think you have to kind of look at the whole picture and use your best judgment. The good news is it's like a very clean indication for surgery for all the reasons you just mentioned, clinical improvement, cost efficacy, etc. The bad news is, especially with elder patients, it can be a bit of a confusing picture at times.
Yeah, definitely. Yeah, that's one of the difficulties is a lot of these symptoms just look like normal aging. So it is hard to say what is just regular aging versus what is degenerative. And most elderly people have some element of osteoarthritic degeneration of the spine.
Hey, so Handy, what do you tell people when they come into your clinic about improvement? Do you tell them that the goal is to arrest, although they stand a chance to get better? How do you frame that?
Yeah, pretty much. I mean, I tell them that success is halting progression and improvement is like a cherry on top. But if we don't improve and we just halt progression, that's still going to be considered a success. And it's important that they kind of frame it in that context, because then you're, at least setting the stage. But at least empirically, I feel like the worse the myelopathy is, the more likely they're going to improve, even if it's been long-standing. But there's more recent data that suggests that there's a good chance they'll get better. So I hedge a little bit, which I think is probably the best way to do it. Even if I tell people, though, it's just to halt progression, they all seem to forget it by the time they come to surgery. And they're like, well, my balance is more or less the same. They're like, well, kind of talked about this, but I still say it.
Yeah. I agree. I think I know that that was the teaching that you got from your senior residents, Ben, but that that's for good reason. It's to make sure that patients' expectations are tempered. There's a recognition they may get some improvement, but patients are always going to be more hopeful than reality. Should lead to. So.
Yeah, and I think that's a great take-home point too, as you sort of venture out into your career, is understanding that, where you set the bar of expectations. Because if you start telling people, well, yes, you're going to improve, and then for that unique patient, they don't, you don't want to end up, with a bad report online.
Sure.
Or they can get worse. There's a small subset of patients that actually get worse.
Yeah.
And
that's one of like the few benefits, I don't know if it's the same way at UT, Ben, but at Scripps, patients all read their notes. Like you write it and then you share it with them, and they get a little pop up on their MyScripps account. So people will read the note that you write like 3 or 4 times. So if you mention it 3 or 4 times within your note, then there's a pretty good chance that, it'll at least be in their mind, or they'll be cognizant of it.
Sure.
Most of the other stuff is bad. They'll like message you over Epic and be like, oh, in like paragraph 3, line 4, you misspelled. Can you please go into the chart and change it? But oh yeah, sure. I got nothing else to do. Happy to.
Well, great talk.
Thanks
for giving it your first week, Ben.
Yeah.
Well, great job, Ben.
Thank you.
All right. Any other questions? All right, everybody. Well, have a good day.